Let me introduce myself. My name is David Cantor. I am the Executive Director here at the North Campus Research Complex. And I extend a very warm welcome to everybody here. We have many people from inside the university, but we also have many guests from outside the university. The symposium today is co-sponsored by the newly formed Institute for Health Policy and Innovation, as well as the Center for Health Services Research at the Veterans Administration. Interesting, as you came in through the building, you may have noticed to the west side of the campus, there's some construction work on a building that is going to be the new home of the Institute. This institute is going to bring many, many different groups from around the university to assemble in one place. And as a landmark moment, today we actually expect to get from the contractors the substantial completion of that major renovation. Through the rest of the year, nearly 500 people will come and move into the Institute here, forming around about a fifth of the total capacity of the North Campus Research Complex. So the new Institute is going to be a very, very substantial presence here. And as evidenced by the symposium, I hope that it will also have a great impact on healthcare policy, both in the state and in the nation, and that Michigan will again be able to have a very visible presence of healthcare policy. But let me just very briefly, in a couple of minutes, also tell you that this is part of a research community that is growing over the last 2 years. It's only 2 years and about 3 weeks since the first person moved into the North Campus Research Complex after Pfizer had vacated the site. And as of April 1st, we have about 1,200 people working here. And what's interesting is it's a very eclectic mix. While the majority are people from the medical school, we also have now a substantial group from the College of Engineering with a program called Biointerfaces. These are a lab-based group that are going to form a group from the College of Engineering, the medical school, pharmacy, and dentistry, forming a cross-school multidisciplinary research group. We also have the Office of the Vice President of Research, the Tech Transfer and the Business Engagement Center moved here to North Campus. And in the past 14 months, the Venture Accelerator has started, and we now have 18 startup companies based here at the North Campus Research Complex, as well as 2 other more mature companies that have leased space. And also, we have some lease space to the Veterans Administration with their Health Services Research Group. So one of the flavors of this campus is the fact that unlike many other buildings in the rest of the university where you can point to a building and that's the Department of Physics or Chemistry or Law and it's a single school, here we're going to have researchers from many different schools. There will also be commingled with public-private partnerships, and it will be something very, very different, but yet under the umbrella of the University of Michigan. So I hope you will see we're about a third of the way in terms of filling this campus. We've seen very probably growth ahead of what was predicted. And over this next calendar year, we hope that there will be at least another 500 to 600 people here. And this will become a very vibrant research community. So I will pass over. I'd just like to welcome everybody again. I'll pass over to Dr. Yves Kerr, who's going to do the following welcome. I hope the conference goes well. Thank you.
Good morning, everyone. I'm truly delighted to welcome all of you to our symposium this morning. And today we're really going to talk about how policymakers, funders, and researchers can better work together to work together towards the goal that we all want to achieve, the goal of providing effective, equitable, and affordable health care to Americans. And this symposium, of course, is sponsored by the Center for Healthcare Research and Transformation, or CHART, also co-sponsored by the Institute for Healthcare Policy and Innovation, or IHPI, as we fondly call it, the new institute that David just alluded to, and also by the Ann Arbor VA Center for Clinical Management Research. So when we talk about the intersection of healthcare policy and research, I just want to stress that we think about and we define healthcare policy and policymakers in the broadest possible definition. So we include here policies made by local, state, and federal officials, but also by health plans, healthcare purchasers, healthcare systems, public health departments, and indeed other practice leaders. And we're really gratified to see many of those policymakers and positions and viewpoints represented here today. So we are counting on you, our audience, to really drive a lot of this conference. We hope for lively interaction during each of the panels. The conference is divided into discussions among 3 panelists representing the policymakers, the funders, and the researchers' perspectives. But there will be time for question and interaction from the audience, as well as time for discussion during lunch and after the lunch session. After the 3 panels, Karen Davis will punctuate our morning discussion with a call to action for all of us about how we can collaborate more fully to realize our goals of better health care for all. And as I mentioned, you will have the opportunity over lunch to discuss what you've heard, reflect upon it, and we'll also be asking you to develop some recommendations with your table mates that we hope to turn into a set of recommendations that we can provide to the University of Michigan and the Institute for Healthcare Policy and Innovation so that the Institute can better support and promote research that can have the greatest impact on healthcare policy. So, before I begin, I just want to underscore why we're doing this. And I often go back to a quote from Mary Sue Coleman, who said in 2010, it's no longer about publish or perish, it's about partner or perish. And in many ways, the NCRC, the North Campus Research Complex, and IHPI is about partnering. It's about finding ways to partner between policymakers and researchers and funders and finding that common language. And it's that common language that we're going to talk about here today so that we can all achieve the goal so that our research can actually have the greatest impact be used in real world settings and impact people's lives in Michigan and the nation. So with that, we're very excited that you're here. I'm going to turn it over to Marianne Udow-Phillips, the director of CHART, who will lead our first panel. Thank you.
Good morning. It is wonderful to see so many of you here in the audience. We are very excited about having this day here finally because we know, and I can tell you from having talked to all the panelists here, that we are going to have a lively discussion today. It's going to be a lot of fun. We are going to try to do everything that we can to maximize the amount of time we have for discussion. Discussion between the panelists and discussion with you. So as Eve said, for each of our panel sessions, we have some initial questions that we're going to be asking the panelists to respond to, and then we'll open it up to you. So please be thinking about the kinds of things that you want to ask. We'll have folks with microphones in the audience, and we'll have at least, in our panel, at least 15 minutes of discussion from you. So please do think about things you want to ask this panel. Eve told you that we have this very broad view of what are policymakers, and we're kicking off the symposium with the policymakers panel because we know that many of you in this room are health services researchers. At CHART today, we are running a fellowship, and many of our fellows are here in the audience, bringing policymakers and researchers together. And it's the first time we've done this. To our knowledge, it's the first fellowship in the country that actually tries to bring policymakers and researchers together to work on projects jointly. And I can tell you, and I think our researchers who are fellows in the audience would concur, that the researchers really didn't know how policymakers think. And so our goal today is to help you in the audience understand that better. And our panel is going to, I know, get us there and kick us off with that dialogue so that we can all start speaking in the same language, so that we can all maximize what we're investing in research to really make a difference in people's lives, because that's what we're really here for. So I'm not going to spend any time introducing the panelists. You have their bios in your materials, but I will tell you, since I don't think you can read their names here, just the order that they're sitting in. So right here to my left is Dr. David Gifford. And next to David is Fran Parker, head of the VIBA. Next to Fran is Tom Simmer, medical director of Blue Cross, and next to Tom is Senator Gretchen Whitmer. And they're each going to tell you a little bit about what they do from a policy role, but you can see we have these diverse perspectives all represented on this panel. So we're going to start, and the first question that I want to ask each of the panelists to reflect on is to tell you a little bit about the policy role they serve. What is it that they do from a policy standpoint? Because all of them influence how healthcare is delivered, funded, or provided to thousands, and in some cases, millions of people. And so I want them to tell you just a minute about what it is they do from a policy role, and then to give an example of how they have used research in that context. So, David, can we start with you?
My current role is I'm the Senior VP for Quality and Regulatory Affairs for the American Healthcare Association and NCAL. Long phrase. The longer it is, the more likely you are to get fired in a downturn of the economy. But there we represent 11,000 nursing homes and assisted livings across the country. And they created a new department of quality, and I was asked to come in and design a quality program for the nursing homes. They figured out they had a little quality problem. And so that's my current job in policy. Prior to that, I was the health commissioner in Rhode Island for 6 years, working very closely with Janet Olszewski, who's here in the audience today. Probably could give you more war stories than I can, but and there really ran into a lot of policy aspects, and can certainly expand on that with questioning, if people want to, a little bit about how we used research in the H5N1 rollout. And before that, I was the chief medical officer for the QIO in Rhode Island, where we led the CMS National Initiative to Improve Nursing Home Quality and Publicly Reporting. So happy to talk about some policy impact about how to use research in that. I'd say that the quick take-home message is that one of the things I've learned is that everything has merit, and academics keep arguing on the merit. And arguing on the merits isn't going to get you anywhere. And similarly, academics tend to, and I was an academic, I was associate professor at Brown for a while, always like to point out the limitations. And if you point out the limitations to a policymaker, they'll say, next, I want to talk to the person who doesn't point out the limitations, because I have to do something. And because the status quo, as we all know, often is unacceptable, and so we're going to do something. And if you say whatever you have has limitations, then I'm going to go to someone who doesn't say they have limitations. Often the person that you go to has more limitations than you do. You just were too honest about it. So currently, an example that we're dealing with is that we got called into Don Berwick's office in the fall and said, fix the antipsychotic drug problem in nursing homes. And some of that has come about because of research that's been done out there. The post-marketing surveillance that showed that they're harmful, and there's a black box warning. And despite that black box warning, there is a continued high and increasing use of antipsychotics in all settings. It just happens we have better data in our setting, so it's actually more evident in the nursing home setting. And so we've been trying to figure out how to solve that problem. So I've been looking to the research to try to figure out, how do you change prescribing behavior? How do you change organizational culture? How do you change family members' perceptions about information out there? And I can tell you most of the information is buried deep in journals. It's hard to understand, and it requires a lot of work to translate it into ways that CNAs, who are often immigrants who don't have English as a first language, can understand. So that's what we're trying to deal with on a regular basis, and CMS is asking how to roll this out as well. On a public reporting side, I used to be a big opponent of public reporting and all the limitations about public reporting. The data may not be accurate. One thing I've learned is if you want to make the data accurate, you publicly report it, and it's accurate within 3 months. If you tell them that we're not going to report till it's accurate, it'll take you 4 years before it becomes accurate. So sometimes just plowing forward is better, and having to make the policy decisions that the military makes all the time, which is you're going to send that unit over to take that hill, and you know that unit's going to die, because in the end it's going to help you save that. You have to make some of those policy decisions too, that there are going to be people that are going to be harmed by your policy decisions, just like there are people harmed when we give any prescription to anyone out there. You have to weigh those balances. So I'll stop there and let the rest of the panel go.
Great, thank you. Fran.
Thank you. Currently, I'm the executive director of the trust, and for us, we serve about 850,000 retirees across the country. I use research to manage the $4.4 billion worth of spend that we spend per year on delivering the care to the retirees. I was very lucky to know about CHART and have worked with Marianne in a previous life, that the first thing I did when we developed the VIBA is to understand what are we spending our money on, and how do we use research to more effectively understand how care is delivered, where are there gaps in care, how can we create a new care delivery model with our partners, and then what can we do to ultimately take this research and impact the lives of our retirees. There's two specific elements of research that I'd like to talk about, and there's a number that actually research studies that CHART has done, but two specifically I want to give an example of how you can take research and deliver an actionable events out of it. We studied our diabetic population. 33% of our retirees have diabetes. Per month, there are 400 new diabetics diagnosed. When the trust came into being in January of 2010, the irony is, as a benefit, they never provided diabetes education. Now, it's interesting because if you think about the history of the trust, most of the benefits were designed around an active population and never in mind of a chronic retiree population with chronic care. Using the CHART research and understanding more about the diabetes, we actually changed our benefit. We added a benefit. 8,000 people in less than 6 months have taken diabetes education. We provide information with every prescription that is filled. We're doing predictive modeling before the people are diagnosed now with diabetes, all from research that was done with CHART. We use not only the research arm, but we use their clinicians to come in and talk to our team that develops benefits. So from that perspective, it's taking we just use claims data and prescription data because it's all we had. So utilizing just 2 months worth of pharmacy data, we were able to take a study and actually impact the lives of our diabetics. Probably another one that I'm extremely pleased with is we actually looked at our cancer population and what is different about our population in terms of issues surrounding end of life. And we had our data, when we looked at the cancer population, we compared it to the cancer studies that were done by Dartmouth. And it's sort of interesting because what we found is, and what CHART found is that We have more people that have chemotherapy in the last 2 weeks of lives, more ICU care within the last month of their death. Our population is more likely to die in the hospital, and they're more likely to die alone. 49% of our people are single because of their retiree status. We actually took that information, created an advanced illness management pilots with our 4 HMO partners in Michigan. We're now part of a coalition in Flint that we're engaged. They've engaged Gunderson Health System to come in and look at creating the model that they put together in La Crosse, Wisconsin, and we're going to look at advanced directives. But this advanced illness management program that one of our HMO partners did, and it was a blue one in the state, they had a new vendor come in and reach out to people that had an advanced illness through predictive modeling that looked like they were to die in the next 6 months. They called a gentleman. It was the first day of the program, and before the chart research, we wouldn't have known we needed a program like that. They called the gentleman on a Friday afternoon and said, you know, we're from X, and we want to know if you're interested in participating in this program, and we'll help you guide you through your illness and your disease. The man broke down in tears, talked about how his wife had died. He was alone. He was going to have surgery next Tuesday, but he didn't know why he was going to have surgery because he knew he was going to die anyway, but he didn't have anybody to talk to about it. Had we not have done the research, had we not understood that these people did not have a resource and didn't have anyone to talk about, the man would have had no one to talk to. So, you know, when we talk about research, people they think about academic research sometimes as not having an actionable item. And so when I, challenge Mary Ann and her team, if you're going to give me research, give me something that I can use to impact the lives of my retirees. And those are 2 examples. That's what I wanted to share.
Thanks, Maureen. That's great. Thank you. Tom.
Thank you. I think that really is a good discussion because it also shows how people in my position, and I make payment policy for Blue Cross for professionals, and I make medical policy. And I'll sort of talk to you about how I make decisions that might scare you, so I'll warn you in advance. I go to people who have their own sources of access to analytics and research results, and I go to these experts and I get the information from them rather than reading the literature. So the first expert that I encountered when I first came to Blue Cross was Doug Wall, and he gave me the following advice. He said, Tom, there's 3 ways you can pay physicians: capitation, salary, and fee-for-service, and they're all bad. Your payment policy should seek to avoid paying physicians. So the research that showed that information comes to me through an expert. And then I go to Jack Billy, and he says, Tom, you got to analyze that a little bit more deeply, understand, do an A3, understand the root causes, and have a broader picture. And then David Scher and Skip Campbell say you really have to partner. Don't get into this too much pay for performance. It's pay for participation because we're already motivated. If we have the tools and the information we need, we will achieve better results. And they did succeed in doing that. And in these various CQIs, approximately 30 peer-reviewed research papers were published. I read about 4 or 5. So I can't say that the access of the research results got to me through reading the research. It just didn't. But I know David Scher read them all. And I asked him to advise me. And so I get it from the experts. And there's actually quite a few other people in the room who, when you talk to them, and I think that Fran Parker is sort of the lead one because, and also I talking to Phil Stoddard and others at MIPSERS, you realize that everybody's confronting really serious challenges that require us to act on information that's usually derived analytically. It's often at its root based in claims data. So of course, I go to Steve Bernstein, who tells me, do you know what's wrong with this data? And you're basing your decisions on what? Fortunately, I now interact with the people at Chart who do analytics and who also have really good connections with the research community, so that I can now interact with people who I think are more closely connected with the type of information that can help us make sounder decisions than the first types of decisions that I was making at the very beginning, based on the anecdotal advice of particular experts.
Thank you, Tom. Gretchen.
Well, I come to you from the public policy perspective of being a lawmaker, and I think many of you probably assume a lot of what that encompasses, and you're probably right. What I view our role as is making sure that we're making decisions, whether it's state law or it's budgetary decisions, to enact policy that makes sense for the vast majority of people in this state. And that means being good stewards of taxpayer dollars as well. When I look at a couple of the instances that I can point to where research really drove some of my efforts in the legislature, the first would be in my very first term 12 years ago, when I was sitting on the DCH budget, and we were scrutinizing the budget where there was a line item to ensure that poor women in our state had access to cervical cancer screening. But we were not drawing down any federal money for cervical cancer treatment. And so when you looked at the research and you said, wow, no one is making use of this cervical cancer screening that we are making available, does that mean we don't have cervical cancer in Michigan? No. What it meant was that people don't want to know if they have cancer if they've got no way to follow up and fight that cancer. And so we really put forth an effort, and it became a bipartisan effort, to ensure that we were drawing down the federal dollars that were available for that cervical cancer follow-up treatment, and it changed the whole program. And that's one example of how research really kind of impacted something that you would assume was happening but wasn't, because the dots hadn't been connected and the scrutiny hadn't happened and people weren't talking on both sides of the aisle. And that's one, I think, example of how the research changed the public policy at the state level and improved lives of many women across the state of Michigan. Another, very solid example that is very related to what some of the research that is happening here at University of Michigan is the stem cell issue. And I point to the stem cell issue because it's not an issue that is inherently partisan. There are people on both sides of the aisle who felt both ways on the stem cell issue, but we had a problem because we couldn't get the legislature to adopt a policy that said we're going to permit this cutting-edge research to happen in the state of Michigan. We were one of only 5 states at the time who outlawed the research and would have thrown people like Sean Morrison in jail for doing it had he used any state dollars toward that end. And so we had to go through the referendum process and amend our Constitution, and it was a bipartisan effort and one that we had to sidestep the legislature to get it done, but I think that that is just another example where the research was so important in convincing people, because it was one that maybe people had emotion at the beginning, but once they understood what it meant and what the possibility meant for economically for our state, but more importantly, in terms of cures for people, that changed all of the momentum, and we changed our state law to become a bit more competitive and hopefully in the race for cures for people.
That's great. Thank you, Gretchen. So all of you in your comments sort of touched on the next issue I wanted you to comment on a little more, which is how research gets communicated to you. How do you find out this information? And there have been researchers here at the university who have said, our role is not a role as researchers. Our role is not to be advocates. Our role is to do good quality research, and that research will speak for itself, and good policy will be made as a result. And so I want to ask you, Tom already said that of all the projects under this Clinical Quality Improvement Initiative, which Blue Cross sponsors. There have been over 30 journal articles. He's read about 4. I do think, David, you probably have read all of them. But, you know, even in your role, and you are probably more tied into the research than many people who are in policymaking roles, he's not able to read those journal articles. And so just doing good research may not get to policymakers. So I'd like you each to address, you know, maybe give some examples of that. How do you find out about what the research is telling you? Where do you get your information? Do you want to start again, David?
Well, I used to like to think I got it when I was in academics. I'd go to Medline and I'd research it, and I'd go to conferences. I know it's actually the way I get a lot of my information is either through the New York Times, Washington Post, hear it on NPR, or the evening news, CNN. Then I may go look up something on it. I get a lot of listservs from government places or other associations, and I just read the little snippets because that's what all I have time for. Mm-hmm. Frankly, I get a lot of information as people call me, and so it's very much like the if you want to be in the news, and a reporter calls you and they're on deadline for 5 o'clock, if you don't get back to them right away, they're going to go find someone else, and then they're quoting someone else who's not as an expert as you, but saying they're the most expert, and then that person becomes the expert because they're being quoted in the press. It's very much the same here. If there's an issue going on, if you're not advocating and reaching out to the policymakers, they're going to make a decision, they're going to do something, and they're going to do something no matter what. And if you reach out and you tell them that the data stinks and it doesn't work and there's all these flaws, they're just going to, I have to do something, you now are irrelevant, you're not helping me solve the solution. Policymakers are trying to solve the solution and make a change, and they're going to make a change. And if you say don't do it, you are irrelevant and you're not going to be part of it. And you need to reach out. So I mean, I get some real nuts calling me with stuff, and you know, I have to listen to them. But I try to reach out to people I know, so it's the relationships I know that get there. But every now and then, someone does pick up the phone and calls me, and I was like, wow, that's really great. Or if I happen to be a policymaker, I'm at a conference and I hear someone talking. So I was at this conference that CMS put on antipsychotic drugs, and they brought in an expert from England. And there's a number of experts on antipsychotic drugs, probably some in the audience here today. That guy spoke. I understood him, I called him, and now I'm going to work with him and use him. And there are a number of people, I just was talking about it before this panel, and someone said, oh, do you know so-and-so, an expert on antipsychotics, in Washington, D.C. and at Johns Hopkins? Like, no, not really. And they probably are more experts than the person in England, but I'm using the person in England because I couldn't find someone in the United States.
That's great. Fran?
Perspective, I too I take advantage of listservs. You know, the internet's a blessing and a curse because sometimes you can't ferret out, as you say, the people that approach you and the information you do get. But I belong to a number of organizations that, like AHIP and others, where they'll have specific research that comes across by disease, by delivery of care, provider models, et cetera. So I take advantage of those. I take advantage of conferences. But same thing in terms of modern healthcare, New England Journal of Medicine, others. And then I have very active board members who send me topical information all the time, and maybe one of them's the same one who used to send Doug and Tom information back and forth. So, but seriously, it's really through colleagues that you have back and forth that you get the information. But then I also have an established partnership with CHART that also helps to provide information as well. So I have built-in relationships and then supplemented by outside sources.
I encounter a lot of sort of initial exposure to research and events through various summary types of things that come through the email process as well. And so we all know about the Accountable Care Act, and we ask, well, which one of us has read it? Well, believe it or not, the team at CHART read that. and have provided a variety of very distilled summaries that help us understand things. I think it's the same thing with research. If you don't have somebody who can summarize it, but also tell you the story behind the story. So we're all aware of the group practice demonstration project, which U of M was a participant and did so very well. And so then we ask, well, how did you do so well? So I go to Dr. Caroline Blaum and I said, well, tell me exactly how you did so well. And she said, well, we don't know how we did so well. But this is what we did, and any one of these things or other things could have contributed to our success. And so I think the real difficulty is getting the story behind the story. We become aware of these big things, and it's really hard to know what are the right conclusions to draw from them, because the sort of superficial conclusions that seem to be presented to you in the way that you receive the material require you to go back to people who have greater depth. And I think that type of interaction and the facilitation of it is a really important way for research results to really figure into policy, because you just can't build policy on sort of sound bites. I've read various sound bites that say that pay-for-performance programs don't work. And, well, how is that program different from this? I've heard that electronic medical records don't work. So in other words, a lot of times the questions are different and the story behind the story is different. So I really do value talking to people whose understanding of the topic goes way, way beyond what I'm able to read through the material I'm exposed to.
And I think one of the inherent challenges as a legislator is that we are required to be generalists as opposed to specialists. We have such a breadth of issues that come before us, and that we do rely on research a great deal, and where we get it can be various places, whether it's the 6 o'clock news that inspires one of my colleagues to introduce a bill the next day, or it is a particular constituent problem that is raised in the produce aisle at Meijer, which happens more than you would think. And coming from a university town myself, before I ran for elective office, I was on the Transportation Commission in East Lansing, which sounds, like a nothing job, but it was so much work because we had professors come in and challenge methodology of driving studies. And so that is one of the benefits to having such great research at our fingertips. But as generalists, we have to be able to ferret through it and distill what the message is, or what the lesson is, and how we can employ that. And so for those of you who work in the legislature or in the executive branch, I know that you've got a lot of people here from state government. I think that relationships and being able to understand and give credibility to research is the biggest challenge, because it's coming at us from so many different directions, and that is the nature of the legislature. It's one of the beauties of it. It's always interesting, but it's also one of the challenges, because we are making such sweeping decisions that impact people. And I lean very heavily on the academic research. I've learned that that's maybe more credible than a hired gun coming into my office.
Do you want to comment?
I just want to add that probably the best example of translating this and getting it out is actually represented by Karen Davis's organization, Commonwealth. They really, the topics they pick, how they distill research down. So they'll fund a research and it'll get published somewhere else, but they'll write a 2-page brief behind the story. I end up using those 2-page briefs more than going back to the original articles out there. So I would encourage you, if you're looking at it, go to the Commonwealth website. They put chart packs together for presentation and PowerPoint. I mean, they've got everything there. And no, I don't have a grant before Commonwealth either.
How important are advocacy organizations, coalitions, having those kinds of groups? Maybe Gretchen, you want to speak to that, because you get hit with so many people with so many diverse viewpoints.
I would say very. As a legislator, I always try to know who my audience is before I speak to them. And I think as researchers, you also need to know who your audience is when you come to the legislature. And the audience is so diverse, come from so many different backgrounds, and it's complicated by having term limits, which means you just have a finite of time to really assess and employ the research that is available to you. And so, we've got legislators who are pharmacists, legislators who are farmers. We got lawyers like me, or realtors, or all different walks of life, and different interests and different aptitudes, and such a steep learning curve. And so I think that it's important to remember the audience and to whom you're speaking, and the coalitions and groups that come together have, I think, maybe an elevated credibility, especially when it's a diverse group that is really trying to solve a problem, as opposed to one group that is trying to advance their own particular agenda.
Mm-hmm. That's great. Great. Okay, I'm going to ask you one last question before we open it up to the group, and you can take it any way you want. You can talk a little bit about war stories where maybe the research piece didn't work so well for you. You can share with the group what you think are really important topics, because I know one of the things that researchers are interested in knowing is how do they, they've got certain topics that they might be interested in. Are those topics that match up with what policymakers are interested in? How do they do that? So take it any way you want, and David, I know you've got some rich experiences that you might want to start with.
All right, I'm going to try something different. Anyone who's been written as a co-author or any paper you've done that has said that there's going to be savings if you implement the policy you've advocated for, please stand up. I'm serious. Stand up. Right? First, I don't believe that. You're not all policy. Look, stay standing, because this has got to be a demonstration. So now the question is, so those who are standing who've written that policy, how many of you are willing to, if you were in a position, say, as Tom, you would actually be willing to put your money where your mouth is and guarantee that those savings would occur? And if they don't occur, you'll take a cut in your grant funding. Yeah, so there's the point. I was in public health, and so you can sit down now, sorry. So in public health, we're always saying that if you do all these things, you're going to save lots of money to the healthcare system. Right. And the finance committee chair used to say, okay, well, if you're going to save that money, can I take that as a cut in whatever year budget that's out there? So actually, we've put in, currently, we're working with Congress on rehospitalization, because everyone says rehospitalization is going to save money. And I'm sure, Gretchen, you've had many people come in and say, if you do this, you'll save money. And everyone just rolls their eyes, and it doesn't get anywhere. So we actually put in the bill that we're going to guarantee the savings. If we don't achieve the savings, we will take it as a rate cut. And I could tell you that all the senators and the policymakers and CMS are like flabbergasted that we're doing that. And so think about, the argument that you're going to save money helps a little bit, but if you're really willing to put your mouth where your mouth is, that means it's really true, because it's kind of like any of those economic analysis. It's just how you put the numbers together, and you can lie with statistics. And probably I'll just stop there.
Okay. All right.
I think for me, what was very helpful, and I don't have the horror stories because I was so grateful to actually have data and an analysis when you're a new organization serving that many people. So for me, though, what has been very helpful from a research perspective is to actually have data with clear, actionable items to pursue. A lot of times you can get the research back, but then, as a purchaser, a researcher, as a utilizer of it, you're looking at it and going, okay, now what? And so for me, being able to take that research and then translate it into ways that can quickly start to improve a model is good. And then also taking that research and being able to continue to pull the string. Much of what we've studied, we had to go back, because as Tom was saying earlier, it's like, okay, but what does this really mean? And it's often when you go back and that second pull and you keep pulling the string is where you find the rich information. I think also from a research perspective, and we talked earlier among my colleagues, that I'm also fortunate that the people we serve we're going to have for life. Oftentimes when people study, particularly if you're just an insurer or something like that, you're only really looking at somebody from a year or two, because then they're going to go somewhere else. And so from a research perspective, I'm really excited about being able to look at the impact from a longitudinal perspective. And so for me, as we build in our studies, I want to actually figure out how do we go back, and then how do we continue to measure, and then how do you take research from a private perspective and then go after the governmental sources such as CMS and then try to compare. So I'm going to use, our ability to take this population over time and measure it. And I think that's the value of starting with a baseline of research and then pursuing it. So the clear actionable items and now then planning for the future of it, I think, is important.
I think Fran really said it when she said the clear actionable items. And I think it is true that we are inundated with people who come with one-off solutions that I think are by definition rework designs, rather than designs that look carefully at the reasons why the healthcare system we have today is so well designed to achieve exactly what it is achieving today, and that if we want a high-performing healthcare system, we have to actually examine the root causes within the system that we have that are keeping us from doing that. And so the questions that I think we want to ask are different often than the questions that the research community is considering, because the context of trying to understand, and I think that Jack Billy's totally right, you really do have to do your homework to understand with something like an A3 what is the system that you're working with in a more comprehensive way, and then ask how can that system change and what are the types of interventions that would create the primary process, one that succeeds, rather than the next 1,000 proposals where there actually has been a research study that having somebody after the fact call and do these other belated interventions does save money, but it misses the point that we don't want to save money by more and more add-on, after the fact, rework things. We want to get in there. And so our research has to be directed to really understanding the system that we're working with and what can make that system work better. And a lot of the stuff that we see is really different from that. So trying to really understand where you are requires a lot of closely working together so that the questions that we're asking are based on where we are, and they will be different questions next year and the year after as we progress in trying to make more fundamental changes to the system, because the types of goals that we have for the performance that the system needs to do, and when I think of the gap that the VIBA or others face when they look actuarially at what they have to spend for healthcare, if it continues on anything like the current trajectory, we need something more than all these things that are the one-off successful interventions.
And I think that the discussion about longitudinal data is something that is an inherent challenge for a term-limited legislature. And, part of it's human nature, I guess, to think about what happens in your own time, but I think we've seen that research has been maybe not valued as highly as what will happen in the next 6 years or 4 years or whatever the term of a particular legislator is, and I think that that's a disservice for public policy as a state. So I do think that that's just an inherent challenge that we face as lawmakers when you have so much partisanship and hyperbole and personal agendas driving votes, as opposed to really looking at longitudinal data and preventative measures that would save dollars in the long run, as opposed to just temporary solutions that will come to fruition within a short amount of time.
Great, thank you. Okay, how about questions from the audience? We have 2 mics. Nancy and Karen each have a mic here. Mark, you want to start? And go ahead. No, Mike is coming right behind you with Karen.
Okay, hang on. Thank you. Good morning, Mark Fendrick from the University of Michigan. I want to ask a question to both David, my longstanding colleague, and Senator Whitmer, to follow up on your point about partisanship. I think that as we stand in academia where we think the world of kumbaya, as this panel went, I'd like both of you to comment on the fact that I find every national poll to show that healthcare policy is alarmingly partisan. And in my brief experience in healthcare policy, it is almost shocking to me about how whether you bring up an issue of the internet or steroids in baseball or global warming or anything in healthcare, that there's almost immediately a line drawn between the Republican and Democratic Party. And I don't think that either one of you, David, from the Washington perspective and from the Lansing perspective, I'd like to see are we truly in the state of gridlock, as the polls would say, or is there real possibility of getting things done from the legislative's perspective on health care, given the divide that we seem to see from the polls?
Well, thank you. I have served in the minority my whole time in the legislature, so I suffer from an acute case of gavel envy, if you will. But I will tell you that I have found some ways to work with my colleagues across the aisle, and I think term limits has made it more difficult. And I know it sounds like I hate term limits, and I do, but it is a continuing theme. When you don't know the people on the other side of the aisle, you can't trust them. And when you have every other year in the legislature, like this is an election year, the Senate is not on the ballot, and we all get along great right now. But the House is all on the ballot, and I think that there is a lot of fighting going on. They're even suing each other at the moment. And so it really makes it very difficult to find common ground on issues where I think we should be able to, where it seems like a no-brainer. The interesting thing, though, I will say about the legislature in Michigan anyway, is the vast majority of things that we do are almost unanimous. And that surprises people when I tell them, but when you look at the bills and how they pass and where the votes are, 96% of the laws that come through are unanimously voted on in favor of, but there are the big issues that create such partisan animosity. And at the moment, I'm the leader of the opposition, and I don't agree with a lot of the public policy that is being jammed through in this one-party controlled government that we have in Michigan at the moment. And it's difficult to see how we move forward as a state, because I think that's what people want. Negative campaigning works, and it has effects into a legislative term, and that's unfortunate because I think ultimately the vast majority of people would say that they want the legislature, Democrats and Republicans, to work together. So it's a frustrating question that I'm struggling with the answer to as well.
Yeah, it's become more partisan recently with a little more gridlock, but a lot of it is posturing for election and who can get in there. And there's still a willingness to work behind the scenes, but you have to understand how they're going to work. The two parties do have different philosophical views on how to approach things. And if you understand that, you can bridge those two with a lot of issues, and you can get some bipartisan support out there. It's a little bit more difficult because it's sort of a continuous election process, but things do get passed, and sometimes they have to make some decisions and move forward out there. If you approach your position that's aligned with one side, then you're going to be viewed as one side, and you better hope it's in the minority or it's not going to pass. If you can try to bridge that, the two sides, you'll get the unanimous passing. Because if you look at the bills that pass at Congress or at the state legislature level, they usually are unanimous. It's rare that they're a very close, tight, split vote on something. Congress is a little bit more partisan than at the state level. But something that goes back to the earlier issue, you need to build broad coalitions and bring them in. If public health walks into the room and there's a bill about smoking, you don't need to listen to the public health person what they're going to talk about. You know what they're going to talk about. You can pick that. If the auto industry comes in, you know the position they're going to take on any bill before they open their mouth. If you brought in someone that's totally unexpected and starts talking about, usually I've found the legislatures, they're at the table, they're sort of looking down, they're checking their BlackBerry, they're doing other things. All of a sudden they're looking up and they're like, who are you? Why are you in this bill? Why are you here? You're usually at labor, and this is the health committee. What are you doing here? And if you can build that coalition ahead of time and bring them in, they will be very powerful, and they pay attention. The other is handwritten letters. You know, these email blasts and everything else. What I've heard, and I don't know, Gretchen, at least in Rhode Island, the legislature said if they get 10 handwritten letters or phone calls from constituents, they pay attention. Because, you know, again, their goal, even if it's term limited, is to get reelected in whatever terms they have. And they are representing the individuals. And if their members are stopping them in the supermarket or anyone else talking to them, they are going to pay attention to it because that's what's out there. So if you can mobilize that group out there, it can be really powerful. And handwritten letters and hand phone calls, the personal aspect is different. The form letters, I got shoe boxes full of form letters, and I just discredited them. But the phone calls, the meetings were much more favorable. I don't know if, Gretchen, you want to expand on that or not.
No, I totally concur with that. You know, I laugh about the person that comes and talks to me in the produce aisle at Meijer, but they get my attention. And they know the bill by the number, which, you know, they think I do too. I don't. I usually have to ask them what the subject matter is. But those are the things that get your attention. You know, people contact me from all over the state, but when it is one of my constituents looking me in the eye or who's taken the time to write the handwritten note or comes into the Capitol, which they can because I live in the capital city, that's what gets my attention. And those types of broad coalitions, I think, do get legislators to put down the BlackBerry and pay attention because when it's a new face with a different perspective, that's something that that is persuasive.
Now, how are, in that context, how are academics looked at? I mean, generally, academics try to be nonpartisan. They may have a view on a particular issue, like the helmet law in Michigan, for example, or smoking laws or whatever. But how are they perceived? Are they perceived as nonpartisan generally, or?
I think so, but I can't speak for everybody. I have learned a lot, just for instance, on the stem cell issue. You know, I'm a lawyer. My background is not in the sciences. That was never my strength. But someone like Sean Morrison, who came in, who is so massively brilliant, but could distill it down and talk to me in a way that not only was persuasive, but I could actually comprehend and re-communicate to people, was an enormously helpful and changed my whole view. Not only changed it, but got me so passionate about the issue that I worked on the campaign to change the law in Michigan. You know, I have had academics from various universities come in and speak with me on a level that, you know, it seemed like it just wasn't something that translated, and that's why I always say know your audience, and that's communication's the first struggle in any effort, and I think that's the key. But I do think legislators are interested in what the people at our research universities are doing and what they are finding.
Fran?
I just wanted to say not only I think that the academic research brings objectivity. And so you talk about when somebody, you know, gives you something, for a person who would report to a board, whether at Aviva or in a corporate environment, you know, a lot of the things that came out of the chart studies, you know intuitively. You know, I would have known from experience. However, there's something about bringing to your board an objective research done by an outside credible institution, and I think there's a value to that academic research because it's not funded by pharma, it's not funded by, you know, a vendor trying to sell something. Well, no, and so I really think there's a value to the academic from an objectivity and from when you bring something to your board.
That's great. Okay, John has.
Okay. Yes, hi, I'm John Pate. I'm a professor here at UM. I'm very pleased to hear all the positive comments about research. It's very encouraging that in certain ways and certain times our research is very valuable to you. But when I look at the title for this conference, Can We Speak the Same Language? That would suggest to me a much more fundamental rift. I mean, once you're saying, can we even speak the same language, someone feels that there's kind of a gap. My wife works in policy and planning. Now she's here at UM. When we were in San Francisco, she worked for the city and county of San Francisco in their Office of Policy and Planning. And she would come home some days and say, you know, this PhD came to our committee, as if that was the worst slur you could make. This PhD from Berkeley, right? But it really suggests, you know, this fundamental frustration that, you know, that she had with the academic researcher. So now I'm originally from Wisconsin, so I know here in the Midwest we like to be really, really polite. So I'm just kind of curious, is that what I'm hearing? Is it really that good? I mean, what I'm hearing this morning is that we do speak the same language. We might need to tweak it a little bit, but things are going actually pretty well, and we should be gratified by that, or are we just really, you know, trying to start off on a positive note?
All right, Tom.
Coming from Blue Cross, we never start off on a positive note. So I think it really depends on whether the question that the researcher has asked and the manner in which they've studied it can connect with what we consider to be actionable. And we have plenty of people who fall into each, and I don't think we can conclude that because they are academic or have a doctorate and this or that. It really depends on whether or not the way they approach their work connects with what actions we need to take to solve the problems that we're confronted with.
David, do you want to comment on that?
No, well, I would agree. How it's framed and presented is key. If it's presented in an arrogant way, if it's presented in arguing about beta coefficients, you know, it's dead in the water. If it's all just about complaining and not providing solutions, it's dead. I do think the academics are, in general, respected as someone independent, certainly more independent than, say, myself. Because if I come in, I'm going to be representing the providers, and I'm suspect no matter what. I'm just like Big Pharma.
But do you think we have a problem with the language? I mean,
yeah, I do think we have a problem with the language.
Yeah.
In general, I do. I mean, there's a few academics who've really figured it out, and they're the ones who tend to get called back and forth. If you're not getting called, you haven't figured out the language.
Yeah. That's good. Others? Fran and Gretchen, do we have a problem with the language? Sometimes researchers, as you said, may not have heard her, but as you said, a lot of researchers may come in, and probably more than not, and speak here, and you were left with, okay, what do I do about it, right? What does that mean?
Right, and that's the know your audience question. You know, before I ever address anybody, I like to know who's sitting in the audience and who I'm talking to. Not so that I can tailor a message to them, but so that I can communicate on a, in a way that is meaningful and creates a meaningful exchange. And I like I told you about the background of the legislature. We're from such very different backgrounds, from different parts of the state, and have different interests and different concerns and different constituencies, and it's the beauty and the struggle of this type of a body coming together and making decisions together. But I think, every single person who runs for office is interested in trying to do something that benefits the people that they represent. And what that means is different to everyone, but at the end of the day, I think everyone has that same core value that inspired them to run. And once you can figure out how to bridge that communication gap, you can see action from people with all these different backgrounds toward the same end. And so I think it's exciting, but it's a challenge.
So I just want to ask, I know you want to comment too, David. I just want to ask you one question, and also I know, Jack, you want to make a comment as well. When you're struggling with a policy issue, all four of you, would you go to a researcher, an academic researcher, not a translator like CHART or a Commonwealth Fund, but an academic researcher, and say, could you help me figure out the answer to this? Would that be the first place you would go? Or would you go to somebody? Depends.
Generally not.
Yeah, and why? So why not? Why generally not? Because what?
Because I'm looking for solutions on how to solve the problem, not understand it further.
Okay. Okay. And so your view, so going back to John's point, I mean, this is a constructive panel. They are trying to help, I think, give a perspective on what works. But what you're saying, I think, at core, is that the way you view research is that generally it's a discipline that's trying to figure things out, but you've all said this, but they may not come forward with things you can actually act on, right? So they may not be the ones you turn to for the first question.
I think academic research has really helped say there's a problem that needs to be solved.
Yeah.
And so in that sense, academics has been very effective. And so policymakers are then going to go out and try to solve it.
Right.
But if the academics keep saying, well, you need to know more before you solve the problem, or your solution may make it worse, where we're not sure, then, okay, there's enough problems, I'll go fix some other problem.
Right. Okay.
I don't tend to contact people to get information whom I've never met and don't know. If the issue is something like the physician group practice demonstration project, and I know the lead researcher on that, I go directly to that person. Because we have so few conversations and we don't meet each other, we don't talk. And I do think that has been one thing that CHART has been very helpful for me personally, is it just gives me a much better venue for meeting the people who I can then go to. And I would go to them first if I knew who they were and I knew what their expertise is and what type of value they could offer to me.
That's great. All right. Jack, you've been waiting patiently. And all right, we'll do two more quick questions, and then we do need to transition to the funders. Go ahead, Jack.
So I'm Jack Billy, the one that Tom Simmer accused of being a compulsive, lifelong root cause analyst, and I am a member of Root Cause Analysts Anonymous. But but a couple of observations about that. H.L. Mencken said, "For every complex problem, there's a simple solution, and it's usually wrong." So I do think that it's quite interesting that, especially David saying, well, you're looking to the solution to a real-world problem, and the academics may not be oriented towards that particular time frame. I think what's striking is that we're actually all in the same business. We're actually all running experiments. The difference is the purpose of the academics is to run an experiment to discover and disseminate new knowledge about a particular aspect of the world, and the purpose of the policymaker is to run experiments in order to make a real-world problem better. But I haven't heard as much about something that's intrinsic in the researchers, which is the sort of checking of the results, the modification of the hypothesis, and then moving on to the next experiment. So maybe our panelists can tell us a little more about when you put a policy decision into effect, the check and adjust part of it that's intrinsic in what the scientists do, and yet I don't often hear about that. We pass the bill as if it'll solve the problem.
Want to comment? Do you go back and look and say, did it work? You do.
We have, and the programs that we've implemented, we've gone back, we've seen, are people participating? Are they still participating? Do we scare? So we're actually building in, and that's why I said I think we have the luxury of the longitudinal, so we can actually study, implement. So it's always that plan, do, check, act, plan, do, check, act, and keep going back and forth. So we plan on it, yes.
Yeah. I think it's a challenge in the legislature because of the timeline, right?
Right.
It's part of your...
Yeah, I would say along that same theme, it is a challenge in the legislature. Proposal A was enacted, and there's never been a commission to go back and really analyze whether or not it achieved all the goals that it was set up to, whether or not it should be changed to adjust for things like declining enrollment, because it's got such an impact on our schools. No one's gone back to do that, and just the utterance of a tweak almost cost Jennifer Granholm the election when she ran and she was talking about Proposal A. I think there's this concern about delving back in and redoing something that was very tough when it was done, but there's a desperate need to do that, and I think it's such a great challenge, and maybe it means that the administration or the executive branch has more authority or the ability to be more creative and do that, but the will has to be there in the organization. So I think it's a struggle.
All right, one in the back, and then I think we're going to have to transition. But the panel's mostly going to stay through the day, so we'll have more conversations. Go ahead.
Okay, I guess I feel inclined to speak in multiple personalities, and that's because I come from the corporate background. I am a financial person by nature or by initial training, and I now am also a doctorate professor. So who comes from the Henry Ford Health System as a financial manager, St. John Health System as their healthcare delivery management, and DMC as contract compliance management, who then has had the audacity to pack up her corporate desk when she completed her dissertation in 2006 and developed a healthcare delivery model that said in order to address the uninsured crisis, you have to expand government involvement in covering the uninsured, which then led me to the Michigan Department of Community Health because it was imperative that I be in a policy role to enact my dream come true. So now that I've circled those multiple personalities, and I do teach at the University of Phoenix Online in the College of Health Sciences and Nursing. And for the Department of Community Health, I was hired as the program analyst for long-term care because I felt since 70% of the problem and 70% of the resources were directed toward long-term care, that was the place I had to be. So obviously I have a point where there's not enough pain and suffering in my life. But to talk to all of you, what I think I'm hearing constantly is that there's a communication gap. And I have to admit that when I sat behind the corporate desk and I would see the policies coming down from the state level, I would say, what are they thinking? How do they expect us to implement this realistically? What I think I know now is practical experience is key. So whether you're talking to a researcher who has an idea of what the world should look like, or whether you're talking to a business person who has a bottom line requirement, limited technology, and a business to run in concept of a business, you have to understand that if you don't understand where they are, you can't understand what they need you to do.
Great, thank you. All right, last comments, and then we're going to transition to the funders. Any advice for the audience going forward? David?
I guess to your earlier comment, if you're publishing and waiting for someone to call, you're going to wait a long time.
Okay, thank you. Nope. Tom?
Well, I think we had a chance to really say it, but I believe that the big take-home message was what Fran said, and that is, if you can help us with actionable information, we're really interested in talking to you. I suspect that it won't be through our first conversation that we will discover that you're able to provide us with helpful advice from your research for our need to take action, and it does require a bit more of an ongoing conversation.
Thank you. Gretchen?
I would just say, become a bit more, of an advocate to ensure that people are able to consume your research, and that is, part of knowing your audience too.
That's great. Thank you. And we should tell you that David Gifford has some PowerPoint slides in your materials, and a lot of what he had to say up here covered elements of those slides. But if you have questions, I think you're here all day, right? So please do feel free to chat with the panelists as we go through the day. Thank you all very much, and we'll transition to the funders.